What is up, wonderful people? This is Medicosis Perfectionalis, where medicine makes perfect sense. We continue our physiology playlist. In the previous video, we talked about the neuromuscular junction, troponin, tropomyosin, T-tubules, sarcoplasmic reticulum, etc. But today it's time to talk about the excitation-contraction coupling. First, the nerve gets excited, then the muscle gets excited, and then the muscle contracts. Excitation before contraction. Electricity before light. Please watch my physiology videos in order. Let's answer the question of the previous video. There are two autoimmune diseases that cause muscle weakness. The first disease attacks calcium channels here. The second disease attacks N sub M nicotinic muscle receptors here. So what's the name of each disease? Here are the answers. A is called Lambert-Eaton myasthenic syndrome and B is myasthenia gravis. We'll talk about this one at the end of the video. But first, please understand that the word gravis is a misnomer. Gravis comes from a gravid uterus, like pregnancy, but it has nothing to do with pregnancy. We thought that it had something to do with pregnancy because when you're pregnant, you tend to be tired, but it's actually not related to pregnancy at all. Here is the neuromuscular junction. Now, anatomy and physiology use different nomenclature. In anatomy, this is called the motor end plate, and this is called the sole plate. It's like a foot in a shoe. But in physiology, it's a different nomenclature. This entire thing is called the neuromuscular junction or the motor end plate. And when we say end plate potential in physiology, we mean the potential in the muscle.
Okay, Medicosis, let me ask you a question. Is locomotion the only function of muscle?
Shut up.
Is movement the only function of muscle?
Heck no.
Is the muscle only concerned with motor actions?
Shut up. Your muscles can also feel.
Really?
Functions of the skeletal muscle are many. Yes, indeed. Proprioception, stretch reflex, reverse stretch reflex, also known as the Golgi tendon reflex. There are many sensations and nerves inside your muscles, and they send signals to your brain to tell your brain about your location in time and space. Like just space, not time. For example, here is a sensory nerve supplying your muscle. For sensation, we call this the muscle spindle. And this is the stretch reflex. We'll talk about these reflexes later in this physiology playlist when we talk about the sensory nervous system.
It's coming, baby.
Do you remember the structure of the nerve? Yes, here's the nerve fiber surrounded by endoneurium, perineurium, epineurium. The muscle is the exact same story. A muscle fiber and then endomysium, perimysium, epimysium. You have three types of muscles: skeletal muscles, cardiac muscles, smooth muscles. The difference among the three types of muscles was discussed before in my comparisons playlist in a video titled Types of Muscles. Pause and review. Each muscle is made of muscle fibers. Each fiber is made of myofibrils. Each fibril is made of myofilaments. The filaments are either thin, actin, or thick, myosin. Muscle, muscle fiber, myofibril, sarcomere, between the two Z lines. What's the structural unit of the muscle? The muscle fiber. What's the functional unit? Sarcomere. Actin is isotropic. That's why we call it the I band. Myosin is anisotropic, the A band. Z line here, a Z line here. Between them is a sarcomere. The A band has myosin and some actin. The H zone is a zone within the A band that has only myosin, no actin whatsoever. At the A-I junction, there is the beautiful transverse tubule or T-tubule. It cuts through the chase. Next, there is the sarcoplasmic reticulum with the two terminal cisterna. Basically, these are prisons to keep the calcium in. If the calcium wants to exit, it has to pass by the ryanodine receptor followed by the DHP receptor, and then it goes to the T-tubule to help the actin and myosin kiss each other. Let's make it more complicated. I'll add three proteins. How do you know they are proteins? They end in IN. You have titin, nebulin, actinin. Alpha-actinin is not the same as actin. Be careful. What's the function of titin? Oh, titin. It's a protein that makes tight. Makes what tight? Makes myosin and actin tight. Basically, it's like a spring that keeps them in their place. It limits the extent to which the sarcomere can be stretched. Next, we have nebulin. Nebulin extends the length of the actin filament. And then we have alpha-actinin, which is attached to the Z line. It binds the ends of the actin filaments to the Z line. What's the name of the action potential in the muscle here? End plate potential. And as we said before, the end plate potential is excitatory. Then we have this miniature end plate potential. It happens at rest. Why is this? Because few of these acetylcholine vesicles keep hitting each other, and then some of them rupture, releasing some acetylcholine. This is basically called the Brownian movement between particles.
Is this amount of acetylcholine released enough to cause me to reach the threshold and cause an action potential? Shut up. It's not an action potential. So why do we have it? First of all, it's the Brownian movement. It's in the nature of things. It also helps bring us closer to threshold so that when the actual action potential comes, we'll be ready. Characteristics of the neuromuscular transmission. Unidirectional, always going from the nerve to the muscle. There is a delay because there is a junction here. There is a gap. There is a cleft, and the delay is about half millisecond. This neuromuscular junction transmission can get tired. Why? Due to repeated stimulation, and this will be even worse if you have myasthenia gravis. You'll get tired even sooner, and it's also due to exhaustion of your synaptic vesicles. You run out of them. If you have too much calcium, of course, calcium is the hero of contraction. Calcium will rupture the vesicles. So if you have more calcium, more release, increased neuromuscular transmission. But magnesium is the opposite of calcium. Think of them as two divalent cations that hate each other and compete with each other. And if you remember your parathyroid physiology, there was a relationship between calcium and magnesium, but that's a story for another time. If you remember your loop of Henle and your distal convoluted tubule of the kidney, there was a relationship between calcium and magnesium, but that's a story for another time. Are you starting to get the memo? Birds of feather flock together. These divalent ions flock together. Sometimes they love each other, sometimes they hate each other. Similarly, sodium and potassium, these are monovalent cations. They are like birds of feather, they flock together. Remember the sodium-potassium ATPase pump. Remember that if you have hypertension or heart disease, your doctor will recommend a diet low in sodium but rich in potassium. Are you starting to get the memo? See, medicine makes so much sense once you understand what the flip you're talking about. Next, we have effects of medications. There are medications that increase neurotransmitter. There are medications that decrease the neurotransmission. Medications that increase include the parasympathomimetics. They act as if they are acetylcholine. Some of them are very similar, such as, look at this, acetylcholine, methacholine, carbachol, bethanechol. You see the chol in them? Others are indirect. Basically, they destroy the destroyer. They inhibit the inhibitor. They inhibit the acetylcholinesterase. This is the enzyme that degrades the acetylcholine. When you get rid of this enzyme, acetylcholine will pile up and increase and increase and increase, and it will increase the transmission. And these include neostigmine, physostigmine, pyristigmine, etc. How about medications that block the neuromuscular transmission? Anything that has curare in it, such as tubucorarine, vicuronium, etc. And they block the nicotinic sub-M receptor, causing muscle paralysis, no contraction. We have talked about this before in my physiology playlist, specifically on the videos on the autonomic physiology. This is the neuromuscular junction. You want to stimulate it directly. You can use acetylcholine, methacholine, carbachol, bethanechol, or a small dose nicotine. You can stimulate it indirectly by anticholinesterase or cholinesterase inhibitors, such as neostigmine, physostigmine, pyristigmine, etc. And by the way, this is how you treat myasthenia gravis. You block it by anything that has curare. How does physostigmine, neostigmine, pyristigmine work? They inhibit the inhibitor. They inhibit acetylcholinesterase so that acetylcholine can persist without degradation. This will boost your muscle contraction. Conversely, tubucorarine has curare in it. It's a neuromuscular blocker. If you have watched my anesthesiology playlist, we have talked about the story of the indigenous people and their use of curare. We also mentioned the two doctors who hustled through the jungles trying to get some curare. How does tubucorarine work? Basically, it inhibits N sub M receptors. It's a neuromuscular blocker.
One of your skeletal muscles is the diaphragm. Curare can lead to diaphragmatic paralysis. These neuromuscular blockers are divided into non-depolarizing and depolarizing. Please refer to my anesthesiology playlist to learn more. Now take a deep breath. We'll talk about calcium. Calcium is the hero of contraction of muscles, coagulation of blood. Calcium gives cohesion to the bone. Calcium disorders can lead to constipation. Carpopedal spasm happens with hypocalcemia. Cardiac arrest during systole happens with hypercalcemia. Calcium is contra excitability. If you have high calcium, nerve excitability will decrease. If you have low calcium, nerve excitability will increase. In previous videos, we mentioned that calcium is a membrane stabilizer. That's why you give calcium carbonate or calcium chloride to treat hyperkalemia, because it protects the heart by stabilizing the cardiac myocyte. Please refer to my nerve physiology videos in this playlist. Calcium is contra QT interval. If you have hypercalcemia, this will shorten your QT. If you have hypocalcemia, this will prolong your QT interval. Calcium binds troponin C. There is calcium calbindin and calcium calmodulin systems. Low calcium, increased nerve excitability. High calcium, decreased nerve excitability. Do you remember tetany? Yes, tetany is what? Hypocalcemia, increasing my nerve excitability. That's why you get carpopedal spasms. Positive Chauvistic sign and positive Trousseau sign. Check out my playlist called Science in Medicine. Now please pay close attention. Calcium is contra excitability if you're talking about the nerves. But calcium is the hero of contraction if you're talking about the muscles. The nerve and the muscle are two different things. If I have hypercalcemia, the nerve will be inhibited, but the muscle will contract more. Conversely, if I have hypocalcemia, the nerve will be stimulated, the neuromuscular junction will be inhibited.
Why is calcium pro-muscle?
Because calcium ruptures the vesicles, releasing acetylcholine, causing muscle contraction.
Why is calcium anti-nerve excitability?
There are two theories. Theory number one, calcium is a cation. It's going to interfere with the sodium, another cation, so sodium will not enter into the nerve and will not cause depolarization. The second theory is calcium will raise the threshold at which the voltage-gated sodium channel will be activated, causing less sodium influx and less depolarization or activation. Back to the story of the neuromuscular transmission. Now acetylcholine is binding to N sub M receptor on the surface of the muscle. The muscle gets excited. The action potential propagates. Action potential will go down through the T-tubules. Once the action potential comes in, this is the signal for calcium to leave the jail. Calcium will leave the prison via ryanodine receptor, and then the L-type calcium channel, basically the dihydropyridine receptor channel. Now calcium is in the T-tubule. Calcium is going to go bind to troponin C. Troponin T is going to bind to tropomyosin and remove the tropomyosin from the actin. This will expose the active sites on the actin. The myosin cross bridge is going to extend from the myosin to the active side of the actin, pull the actin towards the M line. The sarcomere will shorten, the muscle will shorten. #contraction. Welcome to the promised land. Before you get excited, you are resting, and then depolarization happens, which is activation. Now let me ask you a question. When the light bulb emits light, which happened first? The electricity or the light? Of course, the electric current has to come first, and then this will emit light. Same thing happens in the muscle. Electricity first, muscle contraction later. And this is an example of conversion of electrical energy into mechanical energy. Remember the law of conservation of energy. Energy can neither be created nor destroyed, but it can change from one form to another. What's the conduction velocity? 5 meters per second. That's pretty stinking fast. Do muscles have refractory periods? Yes, just like nerves. They have absolute refractory period and they have a relative refractory period. Do muscle fibers obey the all or none law? The answer is yes, just like nerve. What is a muscle twitch? It's a very, very fast, brief muscle contraction due to just a singular action potential. Myosin, 2 heavy chains, 4 light chains. tail, body, 2 arms, 2 heads. The heads have actin binding site to pull the actin, ATP binding site, and ATPase activity. Heads and arms are called cross bridges. Who's hiding the precious active site? Tropomyosin. Tropomyosin is on the actin. Tropomyosin is facing the myosin. That's why we called it tropomyosin. When tropomyosin is hiding the active site, contraction will not happen. But when calcium comes and binds to troponin C, troponin T is going to take the tropomyosin, remove it, and then the active site on the actin is exposed. Myosin is going to extend the cross bridge and pull the actin inwards. After you attach this one and pull it, you get the next one, pull it, you get the next one, pull it, another cycle, another cycle, another cycle, until the muscle shortens. All of this happens in milliseconds. When your muscle contracts, the A band will not change. The I band will shorten, the H zone will shorten. The entire sarcomere will shorten. The entire muscle fiber will shorten, and your muscle length will shorten, as long as you're talking about isotonic contraction. The rest of the lecture is a quick review. The action potential is coming in, moving on the sarcolemma, entering through the T-tubule until you enter the jail. Release calcium from the jail through the ryanodine receptor into the DHP receptor. That's an L-type calcium channel. Calcium is out. Calcium is going to reach actin. Which part of the actin? Basically, it's the troponin next to the actin. Troponin C, to be specific. Now troponin T is going to bind tropomyosin, remove the tropomyosin from the active site. Myosin is going to extend the cross bridges, get that actin closer to the midline. The entire muscle will shrink. Calcium out of the jail, T-tubule, go to the actin, get to the troponin C. Troponin T is going to remove the tropomyosin. Active site is exposed. Myosin, boom, 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 boom. Get the actin towards the midline. Take a deep breath. How do you make acetylcholine? Basically, you get acetyl-CoA and choline, and then you lump them together. Smash them together by choline acetyltransferase. Choline acetyltransferase. Now you have acetylcholine. Alright, acetylcholine has performed its function. How can we degrade it? How can we destroy it? You can break it down by choline esterase, and you break it down into choline and acetate. Bring them back, you can recycle them. The steps of muscle contraction. You start by the nerve. Sodium influx, depolarization, activation of the nerve. That's action potential. The action potential is going to propagate in one direction only. And then calcium is going to come into the cell. Calcium influx, rupture the vesicle by exocytosis. Acetylcholine is out. It's going to bind to the nicotinic sub-M receptor on the postsynaptic surface, creating an end plate potential on the muscle. Action potential propagates on the surface of the sarcolemma into the muscle via the T-tubule. Open the calcium channel, first ryanodine receptor, then L-type dihydropyridine calcium channel, and then calcium is going to bind to troponin C. Tropomyosin is removed, uncovering the active site. Myosin binds actin. Myosin brings actin closer to the midline. Boom, contraction. Pause and review. How does myosin and actin bind each other? We have 4 steps. Binding, bending, detachment, return. Again, binding, bending, detachment, return. Binding of myosin and actin together. And then bending. The myosin is gonna get that actin, grab it, and pull it towards the midline. It happens between the heads of the myosin and the active site on the actin. This requires ATP and ATPase activity, both of which were present in the heads of the myosin. Next, detachment. Believe it or not, detachment also requires ATP. You need energy to separate the actin from the myosin. What if I don't have energy? You will get muscle contracture. Let's say I was playing football for a long period of time. After 35 minutes, I'll get so tired. Why did medicosis get tired? 2 reasons. Number 1, accumulation of lactic acid because of the anaerobic glycolysis. Reason number 2, muscle contracture because I ran out of ATP and therefore I could not detach the actin from the myosin. That's why I don't play football. Just joking. So 4 steps: binding, bending, detachment, return. Only 2 steps require energy: bending and detachment. Myasthenia gravis is a disease where you have autoantibodies destroying your nicotinic sub-M receptors. Now your muscles cannot contract. You get fatigue. Let's review myasthenia gravis from Picmonic. Myasthenia gravis, mice, thin, I, graves. What do we have here? We have antibodies against acetylcholine, acetyl-CoA. What are the symptoms? Ptosis. Here is the toast. Diplopia or double vision. The more you use the muscle, the weaker you get, and this happens very quickly. A cause of death is respiratory failure because your diaphragm gets weak easily. Myasthenia gravis is associated with thymoma. How do you treat it? Acetylcholine esterase inhibitors. Plasmapheresis, basically you're washing out the patient's plasma to get rid of these autoantibodies and replace that plasma with brand new plasma that doesn't contain the stinking antibodies. If the patient has thymoma, you should remove it. Thymectomy. Quick note for the exam. If the question is asking you what kind of antibodies are seen in cases of myasthenia gravis, the answer is antibodies against acetylcholine receptor. This is the nicotinic sub-M receptor. What if this is not a choice? Choose anti-Musk antibodies. Just imagine that Elon Musk has myasthenia gravis and you'll get it right. If you like this video, you will love my CNS pharmacology course, my autonomic pharmacology course, and my endocrine pharmacology course available on my website, medicosisperfectionalis.com. Thank you for watching. Please subscribe, hit the bell, click on the join button. You can support me here or here. Go to my website to download my courses. Go to Picmonic for animated medical mnemonics. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.